It's worse. What we're going to talk about, and I'm going to try to give you the clinical perspective of our experience and when I talk about bone marrow, and I try to keep this simple. Again, it's back to being a surgeon, right? So we're going to take a really complex subject matter and what's not as complex as it has to be. People are making this way more complex than it has to be. We're going to go through the normal pathophysiology of the human body, everything you learned as a freshman medical student and then undergraduate basic sciences. And then we're going to transfer that over to everything you know as a clinician in the operative theater. So we're going to just make it the who, what, when, where, why, how. All right? So this is the clinical decision making on bone marrow aspirate concentrate. Bone marrow aspirate concentrate, what we're going to describe that is how do I add this to your treatment arsenal? What right now are, actually, wait a minute. Okay, he's got a snap. So, there we go. Who, what, when, where, why, how. My goal, and now we're on the right track. My goal is just to make you think of what are the problems in your practice that we can make better. Is there something easy, biologic, safe, FDA approved, legal, to take care of your problems in your practice? Every orthopedic practice has problems that are unsolvable or difficult. Osteoarthritis, it's not unsolvable, but it's joint replacement. Everything else is palliative care. Graft failure, I do 80 allograft ACLs a year. Graft failure, and when you want to make that switch to an allograft that's faster, easier, less morbidity, no graft harvest site, what you want to do is what can I do to make that graft heal faster and fail less often? Avascular necrosis, unanswered problem. We recorded compression is horrible surgery. Is there any way to make that surgery better? There is. Non-unions, of course, as an orthopedic surgeon, I don't see those in my practice that I initiate treatment on, but I certainly have to take care of other people's, right? Isn't that what we all say? Soft tissue injuries. And what I mean is, by this, is when I say I want to make my bad patients better, every one of us knows if you have an 80-year-old diabetic with some systemic illness on long-time form of steroids, with a rotator cuff tear, she's a bad patient. You need to find a way to help that tissue in that patient not be an 80-year-old diabetic on steroids. You need to take that patient's tissue and make it easier to heal, kind of tilt the scale in your favor a little bit. And the other, one of the most irritating treatments in the young, healthy, active 50-year-old male is the chronic kind of recalcitrance treatment, tendonitis of the elbow, Achilles, the tendon, quadriceps after a total knee. What can I do to change the blood supply to kind of tilt things in our favor? So what we're going to do is we're going to go through the who. And the who is, all these we're going to group together. Bone marrow aspirate concentrate is the same thing as bone marrow stem cells. It's the same thing as bone marrow mononucleated cells. It's the same thing as mesenchymal stem cell. It's the same thing as the pluripotent stromal cells, the skeletal muscle stem cells. So when you go through the articles, and we can get your search, anyone here that wants it, the article search, when you go through all these articles, and there are hundreds of articles out there every year now, so it's the leading portion of publications in all the orthopedic literature now. It's overtaken joints, it's overtaken hand, it's overtaken even spine, where those where all the big winning guys are, is biologics. And I'm not talking about reading a rat study. We're talking about something that makes a difference in your patient group. Go through a little bit of the basic science, really quick. We're not going to spend a lot of time on this because hopefully, even from our orthopedic background where we try to forget as much basic science as possible, we're going to focus on the pluripotent nature of the cell is not what we're focusing on in what I do. It's important, but it's not the reason that we're using these cells. When you talk about the MSC, the pluripotential nature of the cell, it being able to influence and become all these different tissues is really important. But we're missing out on the most important uses of a stem cell. We're talking about autologous cells, a concentrated volume from you. We're going to talk about the immunosuppressive effect, the anti-inflammatory effects, briefly, because we are involved in just reviewing the the anti-infective, the cytoprotective effect to help prevent infections, and I'll kind of present a little preliminary data on that. And then we're talking about the secretion of soluble growth factors. We're talking about trophic factors. We're talking about trophic factors. We're talking about the things that, what does that cell do that makes it so unique and so protective and that helps your surgical results? Differentiation of the stem cell, the what. Here's the first what. So we went through the who, the first what do they do? Chondrogenesis. This is when you talk about the pluripotential nature of the cell. If we could promote chondrogenesis in an adult knee, that would be dramatic. That would be something useful. Chondrogenesis is a potential for the cell when you go through the pluripotential nature of the cell. Chondrogenesis, osteogenesis, angiogenesis. The chondrogenic process, I'll just present a really brief slide, and the key to this slide is you don't have to know all of this. The cells know this, right? Chondrogenesis, when you talk about mitogen activation, protein kinase, SMAs, SOX9 is the transmit that we want to selectively go down that pathway. It seems like that's the more chondrogenic of the pathway. That's the reason we'll use bone marrow obtained stem cells instead of vascular stromal fat fraction or some of the other culture cells, because transmit SOX9 is really important in the chondrogenic pathway. The production interaction cellular memory, this entire differentiation of the stem cell and the chondrogenic pathway, we understand it, it's basic science, we just need to know, and this is how God does it already, right? This is how chondrogenesis happens. Now we have to find how can we force things down that pathway. Degenerative joint disease. It's why people come to see us, right? Pain, joint stiffness. Everyone in their 50s, statistically, 80% of everybody over the age of 60 is going to see an orthopedic surgeon for some kind of joint stiffness and pain. Palliative care is a $15 billion pharmaceutical industry in the United States. Probably, since the average age of an orthopedic surgeon in our country is now over the age of 50, probably most of the orthopedic surgeons in this audience have taken on the leave, an hour% of their Motrin because we're on vacation, we tried to exercise a little bit. 27 million of Americans over the age of 25 have some kind of a degenerative joint disease or OA or joint injury. That's who what we're talking about affects. The standard of care right now, NSAIDs, viscosupplementation, bracing, arthroscopy, ACIs, resurfacing arthroplasties, total joint. Everything on this is palliative-ish, and I'll say that only because we'll have a brief discussion about arthroscopy here in a minute, because I don't treat degenerative joint disease with arthroscopy. We don't treat, you know, the study that came out that says that arthroscopy doesn't modify arthritis. We're not trying to modify arthritis. We're trying to treat articular cartilage debris, we're trying to treat tears, we're trying to treat locking, catching, giving way, swelling, not arthritis. I've never given a patient the diagnosis of arthritis and taken them to the operative theater. Articular cartilage tears, loose bodies, debris, meniscal tears, synovitis, certainly, because we can treat those problems and make them better, and certainly set the patient up for success if we can help that patient get over the inflammatory change that the degenerative joint diseases cause. ACI surgery, you know, I did that too. Only 1,500 ACI surgeries performed in the U.S. last year. Total joint arthroplasty, the end phase of degenerative joint disease. Let's talk about a little bit of what MSCs have done for the microfracture patient. It's a Malaysia study. It's really small. It's years old, but he was able to look before and after. Something that we very rarely get the opportunity to do in the U.S. And he didn't have the technology we have. They were doing cryopreserved autologous peripheral blood and adding hyaluronic acid to it and showing chondrogenic repair. And if peripheral blood and the MSCs obtained in that make any difference at all, then the MSCs obtained within bone marrow make more of a difference. Equine study, the premise is wrong, but the results are fascinating. You don't have to be one of us to see. I wish I had the laser pointer. Everything on the right is non-treated. If you look at the articular cartilage under B, there's not a lot. You look at the articular cartilage on the left under B, there is a lot. Right? This is a look at the microfracture, only augmented with bone marrow spread concentrate. When you talk about chondrogenic studies, we have an equine model published, we have a porcine model published, we have rabbit studies published, we have a human studies. Most of those are published out of this country, and they're doing things that we have. All the studies were published 4 to 5 years ago using peripheral blood, spun down bone marrow, frozen and preserved bone marrow. We don't have to do that anymore. Rabbit study. The only thing to draw out of this rabbit study is that at 24 weeks, all the subchondral bone was completely healed. At 2 weeks, you literally saw articular cartilage changes in every one of the treatment group and none of the non-treated group. And again, we can get these papers for you that we're referencing in the study. Go through a few clinical slides from our practice. And this is only on the osteoarthritic knee, real quick. Standing x-rays. And again, here's the sad thing about the technology in the beginning, especially 4 or 5 years ago, 6 to 8 years ago when we first started doing this. We're only using this on the most difficult patients in your practice. The one that needs a new knee that doesn't want it. The patient that's activity levels affected and they're not ready for a joint replacement, or they're too young for joint replacement, or they're not healthy enough for joint replacement. This is standing films and a 6-7 month follow-up standing x-ray. You can see a difference on the standing x-ray. Certainly you can see the subchondral bone health is different. I don't know if that's transferring over on the screen. It's not. But there's certainly more of a joint space on the treatment group than the before treatment. This is the MRI of the same patient. You see the osteochondral lesion, the grade 4 changes underneath the patella. On the left side MRI, follow-up MRI, the joint surface is smooth, articular surface is maintained, subchondral bone health is different. Looking at the coronal images, moth-eaten appearance and the intertrochlear groove underneath the kneecap on the left, restoration of the joint surface on the right. My favorite patient, mainly because my mother referred her to me after sitting next to her on an airplane. That's not a joke. And probably every surgeon in here, his mother is still her biggest fan. The left side, and I wish these films were taken from a little bit farther back, because she had about a 15-degree varus collapse. Subchondral bone health is lost, pseudo-laxity and stability. 4 months. Patient's a doctor's wife from out of state. Came down to see me based on my mother's recommendation on using stem cells. And had nothing else than an arthroscopy, removal of the debris, changes in the articular cartilage, the abrasion chondroplasty, treating the meniscal tears, and the administration of a bone marrow spread concentrate at the time of the surgery without a follow-up injection. Patient returned, walking, activity level different, pain scale dramatically different, and the standing films were different. So when we saw the standing films, in my haste, because I couldn't believe what we were seeing, we ordered a follow-up MRI, which is down the hallway. That's the articular cartilage difference, and you can see the difference in the articular cartilage depth. And you look at the posterior condyle of the femur on the before treatment patient. Nice, thick, healthy articular cartilage on the non-weight bearing surface, where you want is on the weight bearing surface, right? But you can also, on the post-treatment group, see not only a difference in the articular cartilage covering that joint, but you see a difference in the subchondral bone health. And what you're doing with bone marrow spread is you're literally blocking off these channels of wear into the subchondral bone and trying to restore the health of the articular site and of the joint itself. You're changing the microenvironment of that joint with the bone marrow spread concentrate. You're restoring the normal MMP activity. You're getting rid of the cytokine cycle. All that's initial healing phase. You're moving everything to the right into more of the farther down into the remodeling stage. the longest studied action of MSCs. Pretty much most of the original literature on MSCs, bone marrow concentrates in the spine. Most of the spine fusion literature, and in the article, and we're not even going to go through many of the articles because the literature is replete with articles comparing treatment and non-treatment sides. I'm going to present a couple of them. And part of the reason for the fusion literature, the osteogenesis effect, and for the chondrogenesis effect is angiogenesis, the improved blood supply. One quick basic science slide, and we're going to get past it real quick. This is the healing cycle, bone, tissue, and growth. This is all we're trying to do is augment this at 3 or 4 different phases in what the body's already doing. We're driving angiogenesis with HSCs. We are able to set our hematocrit now, so you want to get rid of a lot of the red cells. You don't want to get rid of your HSCs. All that literature that's the difference between bone marrow concentrated and cultured cells. 4 weeks, marked collateral vessel circulation, healing of the non-union. So the slide, this is one of my favorite slides when you talk about the only thing that they did different in this kid after 6 months of treatment of an open fracture with multiple fasciotomies, with failure of skin grafts, with the dysvascular low extremity. The only thing they did different is they put the equivalent of about 120 cells, about 120 cc spun down with what we would, the volume of stem cells that what we would think of at about 120 cc spun down, inject that in the gastroc around this fracture. The collateral circulation, the angiogenesis, is at 1 month. It's the first phase of healing of the bone, right? The pictures on the right side, when you talk about the bone repair, pretty dramatic fusion after the first 6 months, and a kid that was already 6 months out from this injury, and they were talking about whether it was a limb salvage candidate or not. And this isn't that difficult of a fracture pattern. We all see worse fracture patterns than this. This is just open, but it's not a very complex fracture pattern. The kid is a 28-year-old kid. Because of the compartment syndromes, because of the crush injury, because of the vascular compromise, because of the open fasciotomy sites, because of the environment that that fracture was living in, it never healed. So, spine fusions, the best documented, the easiest way to document osteogenesis with fusions. And I'll go through a couple of things because I think all of us understand from our day, and this is and from every orthopedic surgeon within my era, Delaware was the place to go for your pediatric orthopedics. When you do your spine surgery, you're taking the rib hump off and you cut that off as graft. It's the best graft known to man. You can almost watch bone grow in the dish that you were collecting your graft in. Good study comparing rib autograft with a synthetic osteoconductive matrix with nothing other than bone marrow concentrate. So when you can take a synthetic matrix and compare it head-to-head in the same patient to rib autograft and it become equal, then you've done something. Because not many of us are going to take rib autograft from a non-scully patient that we're not trying to get rid of a rib hump and use that for a spine fusion. Number one, the morbidity of that rib resection is not really within line with what we're going to do to the adult patient that goes home the next morning. It's a patient from our practice. I live in the country. I drive a pickup, as do most of my patients. And this guy had a 6-month-old clavicle non-union because the first 3 doctors he went to told him he needed a plate on it, and he's a competitive shooter. He didn't think he'd be able to put his gun on that shoulder. He never had it fixed. A lot of them told him, man, I'm probably healing its own anyway. This guy's 6 months out, 54 years old, can't climb in his deer stand. Decided he needs it fixed. Didn't want to play it. Standard of care for non-union is compression and grafting, bone stimulator, and probably not the way we treat this fracture, but a rock pin in from the back of the clavicle. That way he doesn't have anything on the front that limits his ability to shoot his gun. Grafted it with bone marrow concentrate and a synthetic carrier, a low glycerin synthetic carrier, because glycerin's bad for our cell walls, causes cell wall lysis, and doesn't really help keep the mesenchymal stem cell in its most active form. It was a 90 cc spin down to about 5 cc's. Patient comes back in the clinic. My PA's taking some post-op films, and my PA comes and says, "What is that?" Well, it's osseous union. In 16 years of clinical practice, and I did a trauma fellowship with Roy Sanders down in Tampa, so we got everybody's clavicle non-unions, and we plated them. Never seen heterotopic ossification with interosseous bony union at 5 weeks. So 5 weeks post-op, I looked at the film, I looked at my PA, I said, "Well, we need to get this guy some therapy." The guy's wife comes down the hallway and asks if we were talking about her husband, and we obviously were. And she said, "He's lying to you. He's been climbing his deer stand for 2 weeks. He does not need therapy." So he got what he wanted out of it, and I got a pretty cool film. The what? We went through the pluripotential nature. We talked about chondrogenesis, which is the reason I started this entire program, was to treat the osteoarthritic knee. If microfracture surgery works at all, a couple drops of bone marrow cannot be the equivalent of 90 to 120 concentrated cc's of those same cells. And microfracture surgery is the standard of care. It's a crummy surgery. The results don't hold up over 2 years. So I'll get off the soapbox on that because I think I have another slide about it. The pluripotential nature, the immunosuppressive effect is what we're going to talk about now. And we won't spend much time on this because most of us don't care. We're not going to be doing baboon studies. Most of us don't even know what graft-versus-host disease is, although that was one of the reasons that prompted a lot of my original bone marrow research, because I don't think it's fair to tell a kid they're going to die twice. Graft-versus-host disease, when you have leukemia and you do the bone marrow harvest and then you put it back, the reaction to the allogeneic potential of those cells is rare, but it has about a 90% mortality rate. And so these kids are getting the cure for their disease and are going to die from it. And the immunosuppressive effect of the mesenchymal stem cell has changed that. And I'll show you that. Baboon skin graft survival. The encephalitis, the model in the murine model for encephalitis is an autoimmune encephalomyelitis. That is the murine model for MS. In a mouse study, MS has been cured in this country. Not talking to the guys in Panama who are culturing their cells up to 30 million to treat demyelinating diseases in adult, which is being done. We can't do it in this country. But in a murine model in this country, we've cured the murine model for MS with nothing more than IV infiltration of a concentrated stem cell line. This is not voodoo or witchcraft. It's published. BMA is not just about the MSCs, and this is what we're going to talk about real quick, because I'm a firm believer that bone marrow aspirate concentrate is my primary source of stem cells, other than most of the grown patches that have that preach that they have allograft cells, because the allograft stem cell counts and the metabolic activity of those cells is not the same as autograft bone marrow aspirate concentrate with the metabolic activity. We've done heat map analysis on these cells, viability of over 90% after the spin, with the cell counts of 1 to 3 million in an adult. The reason that all that's important is not about my MSC count. It's because 97% of bone marrow is whole blood. When you spin down whole blood, the advantages of PRP are the trophic factors: VEGF, FGF, IGF, transforming growth factor. And the reason I put betas is because there's about 5, 3 of them are crucial. Of VEGF, there's 10, right? I'm not going to list all the different numbers and talk about all the different pathways. You guys don't really care. What you need to know is the concentrated growth factors. What you do when you spin down bone marrow is you're getting all the advantages of a great PRP product, not an Orthopedics product, which is 2 times baseline whole blood. It's concentrated whole blood. That's not PRP. PRP means you have growth factor concentrations of somewhere between 9 and 15 times baseline. And there's 9 different growth factors we're trying to concentrate. The main 4 are here. And that 4 is not really 4, it's really 6, because there's a couple of VEGFs and a couple of transforming growth factor betas that we're looking at when we do concentration studies. So the difference in your MSCs when you do bone marrow is the matrix and the concentration of the solution you're developing those in and delivering those in to your patient. So the win, if you're looking at fusion, spine, long bone, small foot and ankles. Anytime you're having a problem with a non-union, a difficult, long recovery or follow-up, the vascular repair, and this, I'll mention this briefly because it's a non-published study, it's still ongoing, and it's funded by a competitor, but not really a competitor because I'm still on their peer review board. There's a cardiac study going on, the treatment versus non-treatment group. The San Diego Heart Hospital literally stopped the non-treatment group from being continued to be performed at their hospital. The reason wasn't because they're seeing this dramatic difference in the ischemia, the angina. It was because their infection rate for the last 20 years is 3%. Their infection rate in the treatment group over the last year is 0. The fusion rate of the sternum, they're taking patients with ejection fractions of 20 and raising it to 49 with a BMA injection. Sports medicine, this is where I obviously am not doing cardiac surgery. I do plenty of long bone surgery, fellowship training trauma, but I'm also got 3 little girls, so my job is to not do a lot of middle of the night trauma anymore. So my sports medicine practice has become crucial to my survival as a father. So we're talking about the surgical and non-treatment, surgical treatment, chronic tendinopathies, ligament soft tissue reconstructions, and how can I keep the sports medicine patient, the early osteoarthritic, osteochondral lesion patient, from being a total knee patient. Wound care, some of the very first uses of PRP were wound care because it cleans the wound, it helps the wound heal, and actually Medicare is coming out with wound care codes for PRP this next year. So, the why. Pretty much, hopefully I've given you the why of why bone marrow aspirin concentrate. Now, it's not just about MSCs, it's not just about the growth factors, it's not just about the HSCs, it's about the fact you have all those in an autologous delivered base that you can do at the point of service, which is the only way you can do it in this country. You only have 24 hours to use this. And really we recommend using 3. So all the desired components of bone marrow aspirin concentrate, all we're trying to do, we are not, if someone wants to sell me a product and it violates what I know is the normal pathophysiology and healing of the human body, I'm out. Because I know how the human body heals a wound. We know how the human body heals a bone. All this product does is augment what the body's already doing. We are, and the reason this says at the bottom, I've got to give Brian Barnes credit for the statement, when it says this is how we won World War II. What I mean by that is, if you're trying to fight a war and you're fighting on a front of a battlefield, we were losing. When we started using technology to drop ship the troops where they were needed at the battle where we could make the biggest difference, we won. That is what you're doing with bone marrow aspirin concentrate. You're helping the body fight that battle at a localized treatment site that it cannot get those cellular concentrations at by itself early on. And when you get down to the why, the real answer is, what else you got that works? When you talk about a clavicle non-union, avascular necrosis, the femoral head and neck, trying to get your spine fusion data to not have a non-union, chronic tendonitis, partial tendon tears, ACL reconstructions. And ACL reconstruction, we all think of this as just an answered question. Homogeneity of a graft, and everyone in here will understand this if you've ever worked with a partner, because it's a treatment versus non-treatment group study. And it's 100 patients. The non-treatment group was the partner who doesn't believe in biologics. The treatment group was the 2 guys who were willing to use biologics on the grafts. Homogeneity of the graft is what they radiographically used as a marker for healing, and there's another paper that justifies and rationalizes that. I accept that as proof, I think, and it's a very well documented study. So we're going to go by, based on the fact that that's already been looked at, we're going to go by the fact that homogeneity of the graft returning on MRI is a sign of graft healing and a successful surgery. Homogeneity on a graft in ACL reconstruction without the use of biologics is 369 days in the study. In the patients that were treated with bone marrow concentrate or PRP at this time was 179 days. So just by adding the growth factor concentrations within the joint, they shortened the time to homogeneity of the graft in half. More importantly, if you're the athlete, is not only your return to sports, but it's your chance of graft failure. When we talked about graft failure earlier, the reason we see graft failure within that first 2 years is because it takes 369 days to have a homogeneous graft within that knee, to have a healed, vascular, structured graft within the joint. All we're trying to do is take an acellular autograft, and I don't care if you're using autograft or allograft, because once you remove it from the body, it's the same. It's not attached to anything. You've pulled it out, you've set it on your back table. There's not a lot of cellular viability. But what you do have is a great collagen graft structure to help heal by adding a cellular matrix to repopulate that graft and return normal, viable, healthy tissue. That's what we're trying to do. Compartment syndrome. And this is the crux of other, there's other companies on the market. The leading indication for their product is CLI. There's a great military study going on. We presented, I presented the original data to BAMSA 4 years ago to a bunch of vets. Most of the great military science and biologic are the vets. And at BAMSA, we started a compartment syndrome study where the post-compartment syndrome patient, they take it in a graft, in a grid-like fashion, inject those 6 months of non-viable muscle being retained within the leg. The rotator cuff in the elderly, I think, is even worse because that's patients I actually have to see all the time that expect a good result. The guy with the post-compartment syndrome leg and fasciotomy, he doesn't necessarily expect to really not hurt when you look down at the leg. But the rotator cuff patient in your practice, that when you open up that cuff and look at it, and it looks like that napkin, it's white, it's avascular, it's acellular, it looks like the covering of a cue ball has been peeled off, and you're trying to get that to heal back to bone. What you have to do is promote not only tenogenesis, but you have to return cellular viability to a dead tissue. What you're doing with bone marrow spore concentrate is restoring cellular volume. Age-related misconceptions. Everyone in here, when I said elderly, probably went, he's using elderly stem cells. And there's several studies to show why. And I actually changed the slide because in the paper that was written, I think it was titled "In the Very Elderly Patient" or "The Very Old." It's octogenarians. And what they did is with the isolation of the chondrogenic potential from the cells isolated in the lab, whether the patient was 80 or 30, the chondrogenic potential of the cells was about the same. Then when we talk about no circulating stem cells in the elderly, you're not going to be able to get stem cell count. Great study just published a couple of years ago where they took, and the body knows the difference, and that's one of the things I keep talking about, because it's not that we don't have to know the basic sciences. It's not that you don't need to understand the chondrogenic pathway, but when the body, the proof that the body knows what it's doing is when you measure a hip fracture patient compared to a total hip patient. If you do peripheral blood counts of circulating mesenchymal stem cells in the hip fracture patient, there's 22% of those patients have peripheral circulating mesenchymal stem cells, and these are patients over the age of 70 years old. In the total hip patients, none of them have peripheral circulating mesenchymal stem cells in that 39 to 101 hour study. The body knows that it didn't need circulating mesenchymal aplastic type of cells in that patient to help heal the fracture. So it's a measure of the trauma. It's that, and what we're talking about is that circulating plastic adherent cell that we're looking for to help us heal. So because I have a 15-year-old and an 11-year-old, and because that thrift shop song will not leave my head, because the first 5 minutes all it says is what. So we went through the what, so we just had the what of stem cells. So we're talking about what proof do we have it works? What proof do we have that microfracture surgery works? We all want proof. I want a white paper. Okay, if you look at all the white papers out there on microfracture surgery, there are 28 review papers, 3,122 patients reviewed. You know the finding in all those papers? Further studies are needed to decide the clinical efficacy of microfracture defined as clinical indications. Microfracture is one of the most common performed orthopedic surgeries for the early deteriorating arthritic sports medicine knee in this country. We all do it. Every time you scope a knee, it's got an osteochondral lesion in it, you perform a microfracture. Do you realize you're performing a surgery that there's really not any great data to show what you're doing makes a substantial difference for your patient? Talking about the osteoarthritic knee, 400,000 cartilage-related procedures, debridement microfractures are the most common. ACIs, again, less than 1,500. OATS, just over 1,000. That's probably not fair. OATS is a great surgery, which is easily augmented with bone marrow aspirate concentrate. Total knee arthroplasties, which I think is a great surgery. It's the surgery that made me want to be an orthopedic surgeon. I grew up in a Cherokee family where everyone lives pretty close. And my grandmother one year when I was about 14 said she was ready for God to call her home because she could only walk. She couldn't work in her 5-acre garden. And she was just ready to go. An orthopedic surgeon named Ed Rice in Oklahoma City when I don't think there was a right and left. I think there was a small, medium, and large, and there wasn't a right and left. Now we're all talking about modular components. He replaced both of her knees. She sold her house, bought a motorhome, and traveled all over the country seeing her friends. At Thanksgiving, she was ready to die. July 4th, she was hanging out on the lake with us. And I just remember thinking at 14, if you gotta work, what a great way to make a living, right? So it's not that I'm not pro knee arthroplasty. I do, 200 totals a year. But the literature is shifting to what we're talking about now. 1998, 271 papers written about MSCs. In 07, 1,700. I like this only because this was the letter written to me after a phone call from the radiologist that reads our films. When we started this microfracture study, and it really didn't start as a microfracture study, it really started as people that just had such bad knees there was really nothing else to do. And I offered them the opportunity for autologous stem cell treatment. And one patient told another patient who told another patient. And in Decatur, Texas, since last January, we treated patients from 9 states, and 5 countries. I'm in a community hospital in the middle of a county with a 70,000 population. So when you have patients from 5 countries and 9 states, it's pretty easy for word to get around in a small county. But the radiologist in Fort Worth, literally, when he started seeing the before and afters, called and wanted to know what I was doing. And you can read, I don't need to read the slide, I hate when people do that. But basically what he called and said, how do you take in patients with grade 4 chondromalacial changes and change them? What's different? What have you done? In all my years as a radiologist, I've never seen that pathway go any way but one direction. So what he concluded is, if you can do anything to change chondromalacia and literally reverse that pattern, then there's something that we're doing that's worthwhile. His real conversations now, because now I've done surgery on his father-in-law from Canada, after that he actually brought down to see me. Now what it comes down to is he has decided that there needs to be a new classification for chondromalacia, not just grade 4, there needs to be a 4S for treated with stem cells, because we changed the subchondral bone health. Really quick, my interest in bone marrow, it's really my interest in orthopedics as a whole, because I was by myself out there for so many years, especially after being at a university trauma program. All I wanted is some simple, elegant solutions to the problems we run into that really don't have great answers. And you all have those. The microfracture patient, really common. They do great for the first year to 2 years. The results don't hold up with the surgery. Is there any way to just tilt the scales in our favor? The clavicle non-union, the foot fusion, the navicular that you had trouble with, that already had a screw in it and it's distracted by someone else. You have to, and they're in your clinic now because you did mama's total. Anything I can do that tilts the scale in my favor, I'm in. And then that just shows my original thought on the microfracture, that if a couple drops made a difference, what could I do with 60 to 90 cc's of the genetic equivalent of that? And that was literally the driving force in the very first bone marrow cases we started doing, outside of the spine fusion patients and the non-unions, for which even a Jones fracture. I mean, that's a nothing fracture in our clinic. I mean, approximate fifth met, right? Who cares? I mean, it's a cannulated screw. Most of us, I don't even do that. Most of us swim in a walking shoe. But the ones that won't heal, it's not very many of them, but it is a problem that you're looking to solve. And now there's a couple of papers written where all that they did, take an 18-gauge needle with the bone marrow spread under a C-arm, inject it in the fracture site with no screw fixation and heal. So now you can take all these little difficult problems that we kind of underappreciate, because it's not every Jones fracture, it's not every clavicle, it's not every microfracture, but there's a little bit of those out there. If we're only using it to treat all the bad patients, we're really not doing all the patients we can make better faster, the ACL patients. We're missing a lot of patients we can make better faster. The problem was access to the bone marrow, right? Again, go back to the trauma background, and you'll see that anyone that's ever done a trauma rotation has put in some pins in the front of the pelvis. That's where most of the driving force on the entry portal, my desired site of harvest, comes from, because it's easy, it's quick, you don't need a C-arm, it takes 3 minutes, and I'll show you that on here in a second. The problem was a jam sheety hurt. I couldn't do it in the clinic. You go to someone with a jam sheety in a mouth in the clinic, it's hard. You doing it on the medial face of the tibia, really unpleasant. And the key was not only the post-op pain, not only the anxiety, but you can't really get a good cell count. You know, especially with the proximal tibia, humerus, calcaneus, to be able to get any adequate cell count and get a high enough volume to do that, it's almost impossible. So what I wanted to do was come up with the device. It was easy, it was intuitive, and because of my, Southern Oklahoma oil-filled brat mentality, uses a little fluid dynamics, lower turbidity of the flow, decrease the activation of the platelets, lower your clot formation, increase the frac zone or the draw zone of the bone marrow to increase your cell counts and the viable product that you're trying to get out. So that's the purpose of this catheter. It's got a tip that won't walk. It leaves a round hole instead of a mallet and a jam sheety, which leaves a hole. It looks like a rock at the windshield, right? And what happens is that hole where you took the marrow out of with your jam sheety, when you pull that out, marrow leaks from that. The problem is all those fracture lines around it, marrow leaks from that too, but it leaks in the subperiosteal space. And so you end up with a subperiosteal hematoma. It can take months to go away, it's tender, it can get infected, and it's unpleasant. If you can create a round hole without a mallet or a brutane, because I got to where I didn't use a mallet, I just pushed harder. Right? You still have a problem getting enough cells, you still have a problem getting a higher volume, but I could do it. With the catheter, we created a plunger that I could safely teach someone to not be using a jam sheeting in the iliac crest, because honestly, not a lot of guys that haven't done trauma in 15 years want to stick a jam sheeting in your iliac crest for a knee scope. Because we overrated the morbidity associated with that procedure. And I don't know overrated, because the jam sheeting in a mallet hurts. But with the Biomac, what we've done is the design is such that the sharp tip that won't walk, you put it on the iliac crest, you drill it in, you pull the sharp tipped catheter out, you put a plunger tip down. The plunger tip creates your frac zone. If there's any Texans here, you know exactly what I'm talking about. You create a frac zone of your draw, so you get a higher viable draw, increase your volumes, and increase your cell counts. And you decrease your clotting, you decrease the cellular activation, because you change the turbidity and trauma of the flow, which is if you have low cell counts after a draw, it's because you did it wrong. You can get a really small atraumatic draw with a high cell count. You have to take your time, you have to pay attention, and don't get in a hurry with the mallet. Anything you do like that, the stem cells are I don't know, it's a mixed audience. I was going to say it's like a date. If you try to rush everything along, it's not going to go real well. right? And what you want is to show that you care about it a little bit. So, do a quick video. I don't know if you'll be able to hear the sound. You ready? So, fingers on the internal aspect of the iliac crest, thumb on the outside, poke hole, catheter through the poke hole, walking onto the iliac crest. Focusing on the position of the crest. Down into the crest. Pull out. You see bone marrow ready being delivered from McKenna tip before you even. And do your aspiration. No real brute force with use of the drill. You can more slowly address walkover, so you make sure you don't slip off the iliac crest on the inner table. You can see by the way I direct my drill, if I was going to slip off, it'd be into the skin anyway, instead of the abdomen. Really easy draw. 45mm catheter. It's not even pumped out of the skin. Big difference in, the amount of force it takes to withdraw the bone marrow aspirate concentrated from the biomac and a jam sheeting. You're not going such a long length. Rescrew that in. Pull that up. 90 cc's of bone marrow draw. Little poke hole. The poke hole's down here. Iliac crest is up here. That's the advantage on the positioning. When you feel the ASIS, put the fingers on and pulling that over to isolate your crest. Now this little poke hole isn't in the same field as my actual incision into the crest. Less pain, less scarring. One of the take-homes there, and the reason I started almost like a Z-track, if any of the guys have ever watched, we never do, but if any of the old family guys do an iron injection when you were rotating, they'd always move that skin, track it down, and pull it up. You want the guys that just jam that thing through the skin, any particular debris, any skin, any hair, especially skin, subcutaneous tissue, gets within your catheter, that's exactly where the MSCs go. So you're low in your cell count. Making a little poke hole with an 11 blade before you put your drill in makes about a 10% difference in your cell count. It's easy on the table. All I do is drill right between my fingers. And the reason they got pretty decent at that pretty quick is because all those trauma pins you have to put in the middle of the night. But this isn't a trauma pin. This is it's a 15 bore catheter that if you position the patient right and bump up that hip, the iliac crest is right in line with it. The pannus falls out of the way. It's real subcutaneous structure. You pull the skin over it because you don't want that getting adhesed into the skin. You don't want to form a fistula. You don't want to form a tract, and it's easy. So the tibia draw. ACL patient. So we use bone marrow aspirate concentrate to repopulate the collagen of the graft with cellular volume. So for the BMA harvest, prep the leg into the field. Fibular head is our target. Tibial tubercle is our guideline for the medial face. Infrapatellar tendon, tibial tubercle attachment, fibular head, medial face is right here. So I'll move the skin over just a little bit so that our incision and the skin are on the same plane. A little bit of mobile skin over the medial face. Nice. I'll make a little poke hole because I don't want a skin plug within my cannula. So the cannula is loaded. It's been flushed with ACDA. Fibular head. Take again, got my poke hole, pull the medial face over, Medial face, aiming towards the fibular head. Pull the cannula out. Stick the trocar down in there to free up or crack that zone for us. Syringes have already been loaded with ACDA. Pull it all the way down. You can see the bone marrow start to come out. Turn that if you need to. Again, on the tibia, it's a little slower, much higher fat content. And it's about 70% of the cell count of any lab restaurant. Yeah, we're good. So, you don't need to watch a 3-minute restaurant. From a treatment perspective, it's the cheapest access, well, it's the only real access you have to autologous cell counts with all the growth factors. And it's a pretty easy instrument to add into your practice.